We are now going to proceed. We have done hypothalamus and pituitary gland. So the third gland we are going to do is the pineal gland. In terms of location, the pineal gland is also located in the diencephalon and usually just behind the thalamus and third ventricle. This is the thalamus. This is the third ventricle, and this is the pineal gland. That region is above the tectum of midbrain. This is the midbrain. This is the tectum of midbrain. So this is the pineal gland above the tectum of midbrain. It's a midline structure, as you can see here. This calcified structure represents pineal gland. Usually it calcifies with age, and this is a normal thing. That, even that, even that. That's pineal gland. That's a normal finding. We may not talk much about the gross parts, but overall, it's ovoid or pear-shaped, and the type of cells within the pineal gland are called pinealocytes. Okay, so this we've said so far. We've talked about the location, we've talked about the overall shape, we've talked about the cell types. Now the hormone that the gland secretes is melatonin hormone. Don't confuse melatonin with melanin hormone. The target organs of melatonin hormone are hypothalamus and pituitary glands. What is the role of melatonin on the hypothalamus? On the hypothalamus, melatonin regulates the circadian rhythm. The circadian rhythm is the day-night rhythm. It's like a biological clock. Gives you instructions of sleep time because it is night, or wake up time because it's day. Of course, if you're a nurse, the situation might be different. The other target organ of melatonin is adenohypophysis. And the effect of melatonin on adenohypophysis is to suppress the secretion of gonadotropins. It suppresses secretions of luteinizing hormone. It also suppresses the secretions of follicle stimulating hormone. So through these, then we can say that melatonin influences reproduction. It also influences the biological clock. Therefore, if you have trouble with melatonin, you can affect any of these two. With regard to the first one, you may have disorders of sleep. These usually tend to occur when there is deficiency of melatonin. And with regard to this, you may have precocious puberty. The suppression of gonadotropic hormones in humans is particularly important before puberty. So if you have deficiency of melatonin in childhood, then puberty might just come early. That's what we call precocious puberty. So the images here represent children who have already entered into puberty despite their age. Maybe a 4-year-old boy and a 3-year-old girl. That's what we call precocious puberty. Okay, the fourth gland we'll talk about is thyroid gland. in terms of its location, the thyroid gland is located in the anterior lower neck, just in front of the trachea. In terms of the gross parts, the thyroid gland has two lobes. This is the right lateral lobe. This is the left lateral lobe. And the two lobes are joined by this narrow region, which we call the isthmus of the thyroid gland. Sometimes it may have another lobe here, which we call the pyramidal lobe, because it looks like a pyramidal protrusion of one of the lobes, pyramidal lobe. Not present in this image, but it might be there. Histologically, the thyroid gland consists of what we call thyroid follicles. And this is how thyroid follicles look like. It consists of thyroid follicles. The follicles are of varying sizes. As you can see here, the follicles are made up of some central material, which we call the colloid, surrounded by a ring of cells. The ring of cells that surround the follicles are known as the follicular cells. So in this image, we see the colloid and we see the follicular cells. Between the follicles, like this is one follicle, that's another follicle, there's another follicle, that's another. Between the follicles, we have some cells which are not lining the colloid. We call those cells parafollicular cells. And so these are the key cell types of the thyroid gland: follicular cells and parafollicular cells. The role of the colloid is to store the thyroid hormones. All right, so this is what you've said so far. In terms of location, it is in the anterior lower neck in front of the trachea. In terms of parts, it has two lateral lobes, the right and the left lateral lobe, and an isthmus between them. The cell types, we have follicular cells and parafollicular cells. So let's follow this column first for this other story. The follicular cells secrete T3 and T4. The name given to T4 is thyroxine. The name given to T3 is triiodothyronine. So we have triiodothyronine, that is T3, and thyroxine, that is T4. The targets for these two hormones are actually all body cells. Thyroid hormones act on all body cells, and the effect is to increase the basal metabolic rates. These are the hormones that promote metabolism. For the parafollicular cells, they secrete calcitonin hormone. Calcitonin hormone acts on bone tissue, and the role of calcitonin is to inhibit bone resorption. Great. So remember what we mentioned about related clinical aspects. If you have high levels, if you have excess thyroid hormones, then you call that hyperthyroidism. If you have low levels of thyroid hormones, you call that hypothyroidism. Hypo or hyperthyroidism can either be primary or secondary, depending on the cause of the problem. If the cause of the problem is pituitary or hypothalamus, then it's a secondary type of a disease. But if the cause of the problem is intrinsic to the thyroid gland, then it's a primary thyroid disease. I hope you've understood that one, because I want to give you a question related to that. Before that question, let's talk about this. So you can have some common anatomic disorders of thyroid gland. An enlarged thyroid gland is what we call goiter. Goiter does not necessarily tell us whether the gland is hyperactive or hypoactive. You can have goiter with hyperthyroidism. You can have goiter with hypothyroidism. You may also have thyroid gland which is not exactly in the neck, but it is behind the sternum. It's in the thorax. It's an ectopic thyroid gland. Ectopic thyroid gland can be behind the sternum, and that's what we call retrosternothyroid. It can also be in the tongue, actually. Then you call it linguothyroid. Or in the pharynx, then you call it pharyngothyroid. So the concept here is that the thyroid gland may be ectopic. Okay. So I want to ask you a question with regard to thyroid disorders of thyroid hormones. This is just to test whether you've understood. So there's a single question that is projected to you now. Read it, understand it, then give you a response here. Let's try to do this in less than 2 minutes. Okay. So you're now looking at your results. Okay, they're coming. Should be there now. Maybe let me hear from you people before I tell you my verdict. So 6 people chose. Okay, okay, 6 people chose. These are case of primary hyperthyroidism. Any of those 6 can tell us why they chose that one. Any volunteer? If you chose primary hyperthyroidism. Okay, how umetoka class? Okay, 11 people chose secondary hyperthyroidism. Anyone to volunteer? Tell me why they chose that one.
Hello. Hello.
Yes, Onesmus.
Yeah, I think it's because TSH comes from the pituitary and not from the thyroid gland.
Okay. Okay, I get your concept. So that's why you chose secondary, yeah?
Yeah, it's not in the thyroid, yeah.
Okay. Why didn't you choose secondary hypothyroidism?
They were elevated, so hyper.
Okay. 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 Right. Anyone else? There are those that chose normal endocrine profile. Anyone? I hope you umetoka class. Okay, let's proceed. You'll see something. So I'm projecting to you some 4 clinical scenarios. In the first one, the patient has low levels of TSH and high levels of T3 and T4. So just use this arrow to know whether it is low or high for TSH and T3, T4. I hope you understand that one easily, so I don't have to tell you this is high, sorry, this is low, low, high, high, then high, low. So my question to you people, let's focus on patient A. The first thing you need to determine is whether this is hyperthyroidism or hypothyroidism. Any volunteer to tell me, patient A, is this hyperthyroidism or hypothyroidism?
Hello.
Yes, Andrew. Mm-hmm.
I think patient A is hyperthyroidism.
Okay. Andrew, why do you say so?
Meaning that the thyroid gland is producing more of T3 and T4.
Okay. So Andrew is right. The diagnosis of hyper or hypothyroidism is based on the levels of T3 and T4. It is not based on the levels of TSH. It is based on the levels of T3 and T4. So having said so, we will expect this one to be hyperthyroidism and also this one to be hyperthyroidism. Then we'll expect B and D to be hypothyroidism. I hope you've understood that. Now, the second thing to then determine is whether it's a primary disease or a secondary disease. So on that, you look at TSH and you correlate with the levels of T3, T4. So back to you people, patient A, we've agreed it's hyperthyroidism. Is it primary hyperthyroidism or secondary hyperthyroidism?
Primary.
Okay, very good. So patient A is primary hyperthyroidism. How about patient B?
Primary.
So that would be?
Primary.
Primary hypothyroidism.
Primary hypothyroidism.
Okay. Let's think through these two. Why did we say this is primary hyperthyroidism?
It's because the thyroid gland is not making enough thyroid hormone.
Okay.
Hello.
Yes.
Because the T3 and T4 are elevated.
So in the first one, T3 and T4 are elevated, so hyperthyroidism. Why did we call it primary?
It's because the thyroid gland is in full. It's not making.
Mm-hmm. In all of them, we have thyroid hormones, yeah? Okay, Erica, let's give you a chance.
It is confined on the cells of the thyroid gland, not the pituitary and the pineal and the adrenal.
Sasa adrenal na pineal imetoka wapi? Okay. The second patient is secondary hypothyroidism, and I want someone to tell me why secondary, not primary. Anyone?
Can I give it a try?
Yes, Onesimus?
Yeah, I think it's because the pituitary gland, the TSH, they were low, so the stimulation was low. That's why the thyroid produced low T3 and T4.
Very good. And that's why it's not primary. Patient B is secondary hypothyroidism. If you look at this one, if you look at the first one, we have elevated levels of T3 and T4 independent of stimulation of TSH. So that becomes primary hyperthyroidism. In the second one, we have low levels of T3 and T4, so hypothyroidism. And why are these levels low? Because there is no stimulation. The TSH is not stimulating the gland. So this is secondary hypothyroidism. That means in the third case, okay, so this, now you'll have, okay, this one is wrong there. Let me just change that for you. That should be secondary hyperthyroidism. Just a second. Let me just change that. Okay, we are there now. Okay, I still typed it wrongly. So this is secondary hyperthyroidism. This third one, secondary hyperthyroidism. Now, the reason why it's secondary hyperthyroidism is because we can see that T3 and T4 are elevated. Why? Because the gland is being hyperstimulated. So that is secondary hyperthyroidism. This is hyperthyroidism. The fourth one. In this fourth one, we are in hypothyroidism despite the pituitary gland trying to stimulate the gland. There are still low levels of T3 and T4. It means the problem is with the gland, not pituitary. So this becomes primary hypothyroidism. Have you people understood this for?
Yes.
Yes, yes.
Okay. Now I want you people to try this one. Patient E. Anyone?
Hello,
Yes, McKenna?
I think it's primary hyperthyroidism.
Primary hyperthyroidism, and I agree with you. Good. How about the last one there? Oh, it has already come. Okay, yeah, so I'm still asking you. This last one, high levels of TSH, normal T3 and T4. Is this hypo or hyperthyroidism?
None.
It is none, I agree with you. But how do you classify this disease? Is this patient at risk of being hyperthyroidic or hypothyroidic?
Hello,
Yes, McKenna?
I think the patient is at risk of hyperthyroidism and it will be secondary.
Okay. Okay,
Oh,
that may not
hypo.
hypothyroidism. The patient is at risk of being
Operating
hypothyroid.
hypo.
Yes, because the TSH levels are high. So you really need high TSH levels to maintain the gland at normal. And that's the point here. It means that if the TSH levels were normal, the T3, T4 levels will be low. So this is what we call subclinical hypothyroidism. Subclinical hypothyroidism. Okay. So back to the question I asked you people. I'm sharing the results again. So who got it right?
Primary.
Normal endocrine.
Nope.
The people who got it right are who now? If you have elevated TSH levels, okay.
Hypo.
You're still not so sure? So the people who got it right is only one person. Okay.
What do you mean, Bruce?
Okay, let me show that again. Only this person got it right. Primary hypothyroidism. Because this is not a normal endocrine profile. It's not normal for you to have a high TSH and then normal T3, T4. That's not normal. So the endocrine profile here is not normal. But what's the abnormality? This person has a primary thyroid disease, except it's being compensated by high TSH levels. They have hypofunctioning of the thyroid gland, which is being compensated by high TSH levels. It is still primary hypothyroidism. Okay. The fifth gland is parathyroid glands.
Huh?
Yes, Frida?
Good morning. So
Good morning.
I think I need some clarity. Let's go back to the slide where we were looking at examples of different TSH levels, T3, T4. And let's talk about the normal, just clarify the normal TSH with elevated T3, T4, the primary hyperthyroidism. E, I don't get it right. Why it's primary?
Okay. So
because
here,
when I'm going to what you said clearly, if I got you right, you said like hyperthyroidism diagnosed by T3, T4 levels.
True.
Yeah. And production of T3, T4 is by TSH levels. Yeah. So then when it's either primary or secondary, you said we correlate. Now I can't correlate the normal TSH with abnormal T3, T4 to be primary, basically. So my contention is the primary element.
Okay, so this one.
Yes.
Okay, so have you agreed that this is hyperthyroidism?
Yes.
Why do you think the gland is hyperfunctioning?
The gland is hyperfunctioning. Yeah, it's hyperthyroidism because the gland is hyperfunctioning. No, I don't get it.
Okay, so the gland is hyperfunctioning. The hyperfunctioning of the gland, is it dependent on TSH or it's not dependent on TSH?
Going by the normal TSH, then the gland is not dependent on the TSH.
And that's what makes it primary.
Okay.
Because if the abnormality is dependent on TSH, then it will be secondary.
Okay.
If the abnormality is not dependent on TSH, then it is primary.
Cool.
Okay.
I got it.
Karim. Right, so parathyroid glands. These are 4 ovoid glands, usually located behind the thyroid lobes. We name them as superior and inferior parathyroid glands. The key cell types within the parathyroid glands are the chief cells, or others called the principal cells. The key hormones which are produced, or rather the key hormone that is produced by the chief cells is the parathyroid hormone, others known as PTH. The key role for PTH is calcium metabolism. Now, it does this by targeting bone tissue as well as kidney. So PTH is concerned with metabolism of calcium, but it will achieve this through 2 target organs, bone as well as kidneys. you realize that we had talked about calcitonin also acting on bone to affect calcium levels. Now we've talked about parathyroid glands also acting on bone and kidney in this case to affect calcium levels. Let's make a summary of the hormones that regulate calcium metabolism. There are three primary hormones that control metabolism of calcium. We have parathyroid hormone. Parathyroid hormone usually promotes bone resorption and also reduce the loss of calcium in urine. So my question to you, let's work with the first mechanism there. If this hormone promotes bone resorption, how will that affect the levels of calcium in blood? Will it elevate or suppress calcium levels?
Suppress.
Okay. If you resorb bone, it means you're breaking down bone. If you break down bone, the calcium that is in bone become released into the plasma. So parathyroid hormone will not really suppress calcium levels. It will elevate the serum calcium levels through bone resorption. It breaks down bone. Remember, calcium is stored in bone mineral. Now, if you're breaking the mineral, if you're breaking bone matrix, then you release the calcium ions into the blood. And so PTH elevates serum calcium. And it's the same mechanism that it's also using, or rather the same intention to, by this mechanism of reducing the loss of calcium in urine. PTH reduces loss of calcium in urine, which means that calcium is retained by the kidneys. If you retain calcium by the kidneys, then you are elevating the serum calcium levels. So PTH elevates serum calcium levels through those two mechanisms. Release the calcium in bone into the bloodstream and retain the one in the bloodstream. Don't lose it through the kidneys. The second hormone that controls calcium metabolism is calcitonin. Calcitonin inhibits bone resorption. If it inhibits bone resorption, it means that calcium will then be held up in bone matrix. So it will not be released into the bloodstream. Therefore, calcitonin will suppress the levels of serum calcium. The third hormone that affects metabolism of calcium is vitamin D. Vitamin D increases absorption of calcium from the GIT. Through that mechanism, it will elevate the levels of serum calcium. It also promotes bone resorption, and through that mechanism, it will elevate serum calcium levels. And lastly, it reduces renal loss of calcium as well as phosphates. Again, through that mechanism, it will elevate the levels of serum calcium. So vitamin D elevates serum calcium through these three mechanisms. Perhaps it's important for you to understand the pathways of vitamin D. Vitamin D comes from two primary sources, either metabolism from your skin when you are on the sunlight, or through what you take in diet. The dietary intakes are usually less, though. The cutaneous metabolism is the predominant one. Either way, the forms of vitamin D that you get either from your diet or from skin it's inactive. It's not really the active form of vitamin D. And this inactive form of vitamin D usually is converted to what we call calcidiol, which is still an intermediate metabolite, not active. This conversion occurs in the liver. The final activation of vitamin D to its active form, calcitriol, occurs in the kidney. The kidney is the one that activates calcidiol to calcitriol. Calcitriol is the active form. That triol is the reason why we call it D3. The triol here means 3. So active forms of vitamin D come from the kidney. And that usually, sometimes we ask you to state endocrine functions of the kidney. So vitamin D synthesis is one of them. Of course, you are aware about the other one of secretion of erythropoietin. Okay, we're done with the thyroid and parathyroid. We now descend to the abdomen. I don't know whether you need another break or we just continue. I suggest we continue because it's now 10:20. Let's continue so that we just finish in good time before 11. So I'll try to push you slightly quick now so that we finish in good time. Adrenal glands are the next glands that we're going to talk about. They're located on the upper pole of each kidney. This is adrenal gland, that's adrenal gland. Each gland has 2 parts. The central zone is what we call the adrenal medulla. The outer zone is what we call the adrenal cortex. Same here. The central zone is adrenal medulla. The outer zone is the adrenal cortex. I may want to call these ones histological zones rather than gross anatomical zones because we see them better in histology. So we have said that the location is the upper pole of each kidney. Histological parts, we said we have adrenal medulla and adrenal cortex. In terms of the hormones produced, the adrenal medulla produces catecholamines. The adrenal cortex produces corticosteroids. Very unique, very different types of hormones. The cells which produce catecholamines are chromaffin cells. They are within the adrenal medulla. The cells which produce corticosteroids are in 3 not well-defined zones. And I want us to talk about those zones. So let's talk about the zones of the adrenal cortex. This is the adrenal gland, so this is the cortex, and this is the medulla. This section has been taken through the cortex and small part of the medulla, which is this one. So the adrenal cortex has 3 zones. Okay, the first one there is the capsule, so leave it alone. This is the first zone of the cortex. This is the second one, and this is the third one. What do we call this first zone? The first zone there is what we call the zona glomerulosa. So the cells in the first zone, you can call them zona glomerulosa cells. These cells are the ones which secrete mineralocorticoids. These are hormones. They are steroid hormones which affect mineral levels. That's why we call them mineralocorticoids. A good example, or the main example of mineralocorticoids, is aldosterone. For zona glomerulosa to secrete aldosterone, it will need some stimulation. The stimulant for secretion of mineralocorticoids is angiotensin II. The role of mineralocorticoids is to promote the reabsorption of sodium and water in the kidney. If you reabsorb sodium and water, it means that you increase blood volume. And if you increase blood volume, it means you increase blood pressure. Now, for the kidney to reabsorb sodium, it will reabsorb sodium in exchange with potassium, which means aldosterone promotes the loss of potassium in urine. In as much as you reabsorb sodium, usually to balance the positive charges, you reabsorb sodium and you exchange that with potassium. So aldosterone promotes potassium loss. Having said that it affects the levels of sodium, potassium, and water, we can make a summary that mineralocorticoids regulate electrolytes, primarily sodium and potassium, and also affect blood pressure by influencing blood volume. The second zone, okay, maybe this is your assignment, you'll do this. I'll not ask you this in anatomy, so maybe you'll be asked in physiology, and that's I thought. Just take it up on yourself. You might be asked that in physiology, not anatomy. It's a whole mechanism that involves the kidneys, the lungs, in terms of regulation of blood pressure. This renin, angiotensin, aldosterone is a very big system, and I believe you'll also be taught about it in pharmacology. Okay, let's proceed. The second zone. So this is the second zone. The second zone is actually the largest zone. We call it zona fasciculata. Zona fasciculata secretes glucocorticoids. These are hormones which affect glucose levels. We call them glucocorticoids. A good example of glucocorticoid is cortisol. For zona fasciculata to secrete cortisol, it will need some stimulation, and the stimulus is ACTH. You'll remember that ACTH comes from the adenohypophysis. This is what we call corticotropin. What do glucocorticoids do? Glucocorticoids regulate metabolism, either of carbohydrates, lipids, as well as proteins. They also act as anti-inflammatory agents. They reduce inflammation. That's why you give a patient hydrocortisol, for example, in cases of inflammatory conditions. And lastly, they are immunosuppressants. And that's why we use them to in transplant reactions to prevent organ rejection. So these are the key functions of glucocorticoids. The third zone is known as zona reticularis. Zona reticularis secretes androgen hormones. The androgens from the zona reticularis will have the same effects like the androgens from the testis. So we'll discuss them together when we talk about androgens of the testis. We've talked about the adrenal cortex. Now let's talk about the adrenal medulla. The adrenal medulla contain what we call the chromaffin cells. Chromaffin cells of the adrenal medulla secrete adrenaline. Adrenaline is an example of catecholamines. Now, for adrenal medulla to secrete catecholamines, it will need some stimulation. The stimulus for production of adrenaline is sympathetic nervous system. So the sympathetic nervous system stimulates the adrenal medulla for it to produce adrenaline. The overall effect of adrenaline will be similar to the effects of the sympathetic nervous system. What I mean here is that adrenaline mimic the effects of sympathetic nervous stimulation. And that brings me to a question I want to give to you now. Now, this is a class discussion question. I want you people to discuss it virtually here, as now I take the attendance of the class. I'm going to divide you into some small groups. So if you have a phone or something, just take a photo of the screen at the moment, because that screen might disappear when I divide you into those small groups. This is a question you're going to discuss with your friend, whom I'm going to assign to you in your group. So we're going to talk about the effects of sympathetic nervous stimulation in those organs there. The understanding here is that sympathetic nervous stimulation will be similar to the effects of adrenaline. So I want you to tell me the effects of adrenaline on the eye, on the heart, blood vessels, respiratory system, and digestive system. You're going to do this in 5 minutes. So something is popping in your screen. Just a second. Okay, so something's going to pop on your screen. Accept the group that I will have given you and discuss the question.
To state the effects of the sympathetic.
Someone has called me to your group. Muko sawa?
Oh yeah, we found our way here. We found our way.
Okay, sawa.
Thank you. Okay.
Can you guys hear me?
So, Komacho, what will
All right, I believe you're back now. So you've talked about effects of adrenaline. Maybe let me just hear two. So we'll pick this on the heart. So anyone just tell me, what did you agree in your group about the effects of adrenaline on the heart?
He said it will increase the heart rate.
Increase heart rate.
Okay, good. So what term do you usually give for increased heart rate?
Tachycardia.
Well, let's say the heart rate was 60, then you give adrenaline, then the heart rate has gone to 90. That is increased heart rate. What do you call that?
Chronotropic effect.
Very good. So adrenaline has a positive chronotropic effect. Apart from positive chronotropic effect, what else does it do to the heart?
Increases contractility.
Very good. And the term given for that is?
Inotropic.
Inotropic. So it has a positive inotropic effect. Good. Another effect on the heart? Frida, you're saying something?
I don't know what I should say, but all the increasing your heart rate and contractions will basically give you a high blood pressure and an increase in cardiac output. So
okay, so maybe for the cardiac output, yes. For the blood pressure, you can mention it under blood vessels. Huh?
Okay.
Yes, but yes, there's increased cardiac output. The reason why there's increased cardiac output is because there's increased heart rate, and also because of the contractility. If you increase contractility, you're going to increase the stroke volume. So you're increasing stroke volume, then you're increasing heart rate. It means you're increasing cardiac output, because cardiac output is a function of stroke volume and heart rate. But there's also something, it increases the speed at which impulses travel from the sinoatrial node all the way to the Purkinje fibers. And what term do we give for that?
Conduction.
Yes, what term do you give to conduction velocity? It's called dromotropy. So adrenaline has a positive dromotropic effect on the dromo, D-R-O-M-O. In a sound kama mother tongue?
Not really.
Okay, all right, so positive dromotropic effect, which means conduction velocity. Also, it will reduce the AV nodal delay. So there are a lot of adrenaline effects on the heart. Okay, that's the only one we'll do. We'll not do the others. I want us to finish by talking about disorders of adrenal gland. So the disorders of adrenal gland that you may come across are these ones. Pheochromocytoma are tumors that arise from the chromaffin cells. These tumors produce adrenaline. So you as a nurse, you might pick this first because of very high blood pressures in a patient. Addison's disease refers to adrenocortical deficiency. You have lower production of adrenocortical hormones. And usually it's both glucocorticoid as well as mineralocorticoids. They're both affected. Crohn's disease is where you have elevated levels of aldosterone. So it's a scenario of aldosterone excess. We had mentioned about Cushing syndrome as that condition where you have high levels of ACTH, therefore stimulating the adrenal cortex, you're having high levels of cortisol. Hypercortisolemia will give you Cushing syndrome. Okay, I believe we should stop there. We will continue this tomorrow before we start on the respiratory system, because I don't see we have enough time for the next, and you need to take your break before you have your next class at 11:30. So maybe we'll stop there. So we'll pick from the pancreas tomorrow morning. We are meeting tomorrow morning again from 8 to 11 for respiratory system. So we'll finish on what is pending for endocrine system before we start respiratory system. So I want to give you more time to also ask questions before 11, but if there's no question, we'll just stop there.